Good afternoon, everyone. Thank you for joining us for this afternoon's Regulatory Relief and Rapid Access in Article 31 Clinics webinar. This is Yvette Kelly with the Community Technical Assistance Center, and I am joined by my colleagues Boris Vilgorn and Connor McCullum. We are also joined by a number of our OMH partners who will lead us through today's presentation. Before we get started, I just want to take a moment to review a few housekeeping items. The slides and recording from today's event will be made available and posted to the CTAC website shortly after today's presentation. So if you have a colleague that wasn't able to join us today, or you'd like to refer back to the material presented at a later date, you will be able to do so. Today's presentation will conclude with a brief question and answer period. So we are asking participants to please submit your questions at any point during the webinar. To submit questions, we're requesting that participants utilize the chat box feature located on the right-hand side of your screen. When looking at the chat box feature, you'll notice there's a drop-down box. If you could please use this drop-down box to submit questions to all panelists, that will ensure that your question is visible for all of us to see. As always, our state partners will do their best to address questions in the time permitted. In the event they're unable to get to all of your questions, they will be collected for review and addressed in future guidance. For any technical difficulties, please feel free to chat to our host who will be able to assist you. And with that, I'm going to pass it over to our first presenter, Nicole Haggerty from the Office of Mental Health, to get us started.
Thank you. And thank you everyone for your time today. Over the past several years, we have heard from our clinics that documentation burden for clinicians has created dynamics where the treatment planning process intended to support thoughtful, person-centered planning has become less meaningful or even driven by the documentation itself. OMH has taken that feedback and implemented the regulatory changes you will hear about today. These changes are just one part of a larger look at clinic, a foundational service within the changing behavioral health system. In the next year or so, we will continue to talk with providers as we consider how to better support integrated care through alignment with OASIS regulation, continued opportunities to decrease regulatory or documentation burden, increase access to peer or rehab services for individuals who may benefit, and considering alternative reimbursement models to better support special populations. So thank you again for your time today. We look forward to your ongoing partnership as we realize opportunities together in these challenging times. And with that, I'm going to pass it over to Stacey Hale.
Great, thank you, Nicole. If we can forward to the next slide. So good afternoon, this is Stacey Hale, Unit Director for Bureau of Rehab Services and Care Coordination, Division of Adult Services. Here presenting with me today is Bonnie Catlin, Director for Strategic Clinical Solutions, Division of Children's Services. So thank you, Bonnie. Thank you to all for taking the time to join us today. And also a thank you to MCTAC, CTAC, for all your assistance with the presentation and managing logistics. So the purpose of our presentation today is to review Part 599 reg changes for treatment planning. And we're going to review the specific changes that were made to 599.10. Towards the end of the presentation, we will have a brief discussion around best practices for rapid access, looking at pre-admission, admission, and assessment practices. And then lastly, introducing rapid re-engagement, which is now supported by the current reg changes. Next slide. So our clinic goals include rapid access, engagement, meaningful plan of care and treatment, wellness, recovery and resilience, support in the natural environment, and rapid re-engagement. So some key strategies here may include things like team or interagency collaboration, engagement processes, timely access, data-driven decision-making, continuous quality improvement. But our goal is to help support clinics to continue to focus on these goals through reg changes and additional forthcoming changes like the move to rehab option under the state plan. Next slide. why regulation updates? As we've discussed, and you may have been to some prior presentations where we talked about this, the Commissioner really supports decreased requirements to allow clinics to focus on quality of care, rapid access, and family-centered treatment. So what you'll see is these reg changes are really about making the treatment planning process more meaningful and improving engagement while increasing and expediting the individual's access to treatment. You may have heard me reference this before because I say it often, but these efforts are to move away from, or to move from treating the chart to treating the individual and the family. And the hope is that these changes will reduce the documentation by changing requirements and then allow for flexibility for clinically driven work and help increase the ability of psychiatrists to provide clinical treatment and oversight rather than just signing off on documentation. So some of you may or may not be aware, but the regulations were actually published yesterday, 8/19. I do not know that they came through on Westlaw as of yet. We were checking, but they are updated. So those of you who may not have been through a reg update in the past, regs are active upon publication. So that was yesterday, 8/19. Publication in the state register is where it's published right now. There's no grace period between the reg becoming active and when you are expected to comply. However, for those who may need some flexibility to adapt with meeting the updated minimum standard, certainly superseding the minimum or continuing to use the higher standard would not be problematic. And just to give you a little idea on where we're at with moving forward, OMH is currently working on updating the standards of care and guidance. Our plan is to be able to distribute the standards of care around October and hopefully the guidance along with that, if not shortly thereafter. And then as of January 2021, licensing will begin to use the updated standards of care. However, this doesn't affect the ability for agencies to make any changes immediately based on these reg changes. Next slide. So now we're going to talk a little bit more specifically about those reg changes. So just to summarize what we're going to be focusing on today of where the regs were updated. Again, the purpose of making these reg changes was to reduce the minimum requirement to really allow for that more clinically driven decision and working with the individual and family rather than required administrative timeline dictation. It's important to understand, though, that these changes being made are specific to process and documentation requirements, not to clinical best practices. So in the regs, we clarified differing billing requirements based on payer. There wasn't any change in this section. It was just moved and the language was made a little bit clearer, but the intent is still the same, so you won't see much change in that. We really just made it align throughout the document. We removed discharge criteria as a component of the initial treatment plan, and this should allow for more of a focus on goal attainment versus the discharge piece of it. We also updated the treatment plan review timeline from being due every 90 days to being due no less than annually or as clinically indicated. Also, documentation of the treatment plan review and updates may occur in progress notes, and we'll get to that a little bit further in the presentation. It will be an agency decision on how you want to proceed with that, but that will be something that is allowable. And then we clarified signature requirements for the initial treatment plan reviews, and updates to the treatment plan. As well as part of that, we also addressed requirements for signatures of the individual or family on the treatment plans, which really allow for more documentation of collaboration versus the signature. And again, we'll go into specifics as we go through the slides. All right, and I will now hand it over to Bonnie for the next slide.
Thank you, Stacy. As Stacy pointed out, the regulation update clarified the requirement differences between Medicaid fee-for-service recipients and for Medicaid managed care or commercial insurance recipients. In practice, many clinics have standardized this, but it is important to understand where there is flexibility. Medicaid fee-for-service must be authorized by a psychiatrist or other physician. Medicaid managed care or commercial insurance offers the opportunity for additional disciplines to authorize the plan. We recognize that the reality of children's coverage is that it changes often, which can make this challenging. Clinics may want to make additional considerations for children due to payer change possibilities. Next slide, please. The regulation update removed the discharge criteria as a requirement from the initial treatment plan. This approach may facilitate a more active discussion, allowing the clinician to listen carefully to discover the outcomes that people or youth and their families hope to achieve from treatment. For them, treatment completion may be an important concept that will help to instill motivation and hopefulness. The initial treatment plan due dates may also vary by payer. Medicaid fee-for-service is due within 30 days of admission. With regard to Medicaid managed care or commercial insurance, please be aware that the plan can determine the initial due date. If the plan does not set the requirement, the initial treatment plan is due within 30 days of admission. Stacy?
Great, thank you. So next slide. So treatment planning and timeline change. I would say out of the regulation changes we made, this is hopefully our biggest win here. And really it focuses on not just that treatment plan reviews are required no less than annually, but allows that flexibility to do them as frequently as determined by the clinician in collaboration with the individual and family. So there's not a dictation for it to be done less than annually, but if there is a need there, it can come naturally that you might update the treatment plan. Treatment plan reviews will be due no less than annually based on the admission date or the most recently completed full treatment plan review thereafter. So you'll see a change in, it won't always be based on the admission date. It will be based on the treatment plan review date of the last one completed that was full. This is definitely considered a big win. I think it's probably our best part of the presentation, so I'm glad I get to be the one to present it. And really the purpose in doing this is to allow for the flexibility in providing services as needed for the individual in live time based on need, rather than based on those timelines that might not reflect actual need. Next slide. So treatment plan reviews using the progress notes. Treatment plan reviews may be documented in progress notes, or agencies may choose to continue to document as you have. Your agency will have that choice. This was a broader effort towards flexibility in clinic, but also towards moving to align with OASIS changes that they have been working on. Some agencies may not elect to make this change. It's your choice as an agency, but you need to have policies and procedures that reflect this, and it needs to be consistent for all staff, so whichever direction you decide to go. If the treatment plan review is done in a progress note, just make sure you're clearly labeling that note and ensuring all required components of the treatment plan review are in that note. Also, this is the part I just wanted to put in here because I thought this would be something that you may want to look at when you're operationalizing this. Really looking at considering how this could look for med-only individuals, where the prescriber could now do the treatment plan review in a progress note. Next slide. Okay, when you have a treatment plan update where services are added or intensity is increased, you will need a physician's signature. Here, intensity means frequency, so how often, like weekly, a weekly psychotherapy appointment, and duration, which means length of the service. So for example, 30-minute psychotherapy or 45-minute psychotherapy. Example of service types include things like psychiatric assessment, psychotherapy individual, psychotherapy family collateral, psychotherapy group, and others, and also would include optional service types like developmental testing, psychological testing, and so forth. I want to point out here, because I think it's important to differentiate between interventions and services. Interventions are not services. Interventions reflect what clinic treatment staff will do to help the individual accomplish their objectives. So an intervention is not something that would need a physician's signature, but a service increase in duration or frequency or an add of a service would require a physician's signature. I also just want to note that this is specific to fee-for-service. You do want to look at the other payer requirements where there's more flexibility, like what Bonnie was talking about earlier in the slides, the difference between what the requirements are for managed care and commercial insurance. Next slide. If only one goal or objective or intervention or time period of achievement needs to be updated, you do not need to do a full treatment plan review. You can review just the goal or objective or intervention or time period of achievement that needs updating. And it can be documented in the progress note, where only the clinician's signature is needed, so no physician signature is needed for that. This allows flexibility we talked about earlier, really allowing for treatment in real time based on need of the individual family. You can focus on being able to develop or change goals and objectives right on the spot, not needing to worry about signatures or doing a full review of the treatment plan. I do also want to add, it is important to keep in mind that best practices, if you are adding a new goal or objective, but services are not changing, still be aware that this change should not dilute the need for collaboration amongst the treatment team of service providers. You still want to make sure that the individual, the family, and others are involved in this decision and making these changes or updates. And now I will turn it over to Bonnie.
Thank you. Although the requirement for a recipient's signature has changed, please remember that treatment plan reviews are a process of gathering feedback and input from the entire treatment team. Remember the spirit of the review and that it's celebrating achievements and the identification of next steps in treatment. This process may result in changes to the treatment plan. It is important that all participants are offered a copy of the treatment plan. Children and families may be complex and have multi-system involvement. The entire treatment plan with updates must be available to both the family and service providers to ensure one consistent plan of care. Next slide, please. This slide provides a treatment plan overview. It depicts an outline of the necessary components of the initial treatment plan in the first column, requirements for plan updates where there is an addition of new services or increase in frequency or duration. This is listed in column 2. Column 3 highlights plan updates for all other changes and edits. And column 4 outlines the treatment plan review timeframes. Next slide, please. As Stacy previously mentioned, this regulation is effective August 19th, 2020, which was yesterday. As clinics determine how they choose to operationalize these changes, there will be a need to update your policies and your procedures. You may also wish to examine your workflows and consider EHR adaptations. Next slide, please. OMH will provide updated standards of care by late fall of 2020. In January of 2021, the updated standards will be utilized during licensing visits. We will also provide updated clinic guidance. Stacy?
Great, thank you. And you can go down 2 slides. Thank you. If some of you were able to join us last winter when we did presentations regionally to begin some of these reg change discussions, these next few slides will probably look familiar to you. I did bring forward some of that information, and then I think it's important for us to reiterate some of that. But my hope is also now hearing it with some of these reg changes, it should be ways that you think about in how to operationalize kind of moving these pieces with rapid access into you know, what the reg changes are, so how that will help that. When we talk about rapid access, there are really these 3 areas to consider. So pre-admission, admission, and assessment, because they all affect access to services in one way or another. So for pre-admission, it's just a status. So most services can be provided during pre-admission. There are only a few that cannot. And pre-admission status should not delay treatment, and I think that's the important part of the rapid access. The commissioner doesn't want to see that somebody's not getting services because they're stuck in a pre-admission status. So things that you may just want to consider in looking at this is, you know, make admission individualized and person-centered, provide services prior to admission if needed, admit sooner when appropriate, replace the idea of contract for treatment with motivational interventions. Focus on engagement, not whether you think someone will come back or not. Don't bet against the individual coming back. And then pre-admission and assessment should not be mutually exclusive. Okay, next slide. Basically, if you've determined that the individual is eligible for services and the client's agreeable to clinic services, then admission is appropriate. At this point, all services can be provided after admission, including initial assessment. There's no reason to delay admission. So the hope is that these reg updates, where we are lessening the focus on documentation, will start to move us in that direction to allow for more flexibility here. And effective engagement is key, and I mention engagement again because it's a continuous process to engage and keep someone engaged, those of who you are serving. Next slide. Assessment is ongoing. So one of the recommendations would be to really consider streamlining the process. Look at your agency processes versus what is regulatory driven, and remove items that go beyond requirements or are repetitive in your assessments. As some of you may have heard, if you were a part of those previous presentations, OMH is also looking at assessments and processes and what is required and what should be required moving forward. So that is something we are taking on as well as for a project. But assessment should be clinic discretion based on the individual needs for screening and or assessment. Look at using screening tools if you're not already using them. Use information that's already available from other sources to complete the assessment. It doesn't need to be all verbal from the individual, like psyches for prior hospitalizations. And I know Bonnie wanted to add to this slide, so I'll hand it over to Bonnie to add to the slide.
Thank you. And we just wanted to add that being able to access services as soon as possible when a child or a family is seeking help is extremely important. and we recognize that not all children and families require the same process for initial assessment. Some may require more than one session to ensure the process is developmentally appropriate and considers the vital role and perspective of the family, while others do not. How best to facilitate engagement and motivation for treatment should always be considered by clinicians. Back to you, Stacy.
Thank you. So rapid re-engagement, this will maybe the first time that you hear this term, but it will not be the last. If you want to go ahead and move to the next slide. So right here, we're introducing rapid re-engagement. The idea is to reduce readmission burden for both the individual and the clinic, and really allow access to treatment immediately. So what we've looked at is with some of these reg changes, re-engagement really is supported by a few things already in existence. The initial assessment can only be done up to 3 times during an episode of care and not prior to 365 days from discharge. So also the current reg changes with the updated annual treatment plan timeframes for no less than annually and the changes in signature requirements, we feel like this would be an opportunity to really look at that. So if an individual is discharged from the clinic, regardless of the reason, and comes back to the clinic prior to a year, looking at providing the opportunity for rapid re-engagement. And so part of the consideration in operationalizing this is what could this look like? So things like immediate and easy access, avoiding being put on a wait list, moving past pre-admission status, not repeating intake, access occurring automatically, no delay in treatment for medications or therapy, no new initial assessment needed, as prior assessments could be utilized. Clinicians can build off of the assessment that was already completed. Prior treatment plans could be utilized. Prior treatment plan reviews could be utilized, updating in collaboration with the individual and family. So no additional treatment plan needed, and working off of what exists, but updating it as needed. Focus on presenting the problem and identify needs, and really looking at charts closed due to discharge, reopening them and documenting re-engagement and being able to go back to them. And so really decreasing a lot of that documentation and repeat of things that might be already available for you. And Bonnie wanted to add to this slide as well.
And we understand the premise is for children and families to have access to the right service at the right time. While no formal initial assessment is required, it may be updated as we recognize that young children and teens rapidly change during this time. And so we ask that all clinicians use their clinical judgment. And as always, services should be individualized, child-centered and family-focused, collaborative and integrated, strengths-based, and trauma-informed. Thank you.
Great. I think at this time we can go into questions.
All right. Thank you. So thank you to Nicole, Stacy, and Bonnie for this presentation and for this incredible news and update. As you said, we are going to move now towards the Q&A. But actually, before we go to questions, we did get 2 comments. And I thought maybe we can start off with those 2 comments and then move to the Q&A. So the first comment we got goes like this. This is really incredible. So much less prescriptive and really helpful in patient-centered care. Thank you. And the second one is thank you to OMH for consulting with community providers and making streamlined changes. So I just wanted to read those comments. And I think we should probably end on that note, because I think those are wonderful comments. What do you think? All right, let's just remember those comments as we get to the questions. So we got quite a few questions and more are coming, and I'll encourage people to continue submitting your questions. Please don't hesitate to use that chat box. We're up to over 30 questions already, and so this is great. Really appreciate it. One of the questions we got, just to kind of, I know it's still on everybody's mind, and there was a question about COVID and, all the kind of rules that came out during COVID and still are, I believe, in effect, including some of the treatment plan leniencies. So that just kind of clarifying, that is still in effect, whatever the COVID rules been out there, and I believe the executive order is still in effect. So just wanted to throw that out before we move forward, because that was one of the questions that came in.
Hi, this is Nicole. I think I could take that one. I think the most important thing to know about that, because that's not necessarily a short answer if we get into all the detail around it, but it's important to know that the current guidance that's on the OMH website is still in effect, specific to clinics, and that as if things change, because of course that environment is ever changing as we navigate through different telehealth allowances and executive orders, et cetera, OMH will update that guidance, and providers will be notified immediately as they were when we initially issued them.
Excellent, thank you. All right, so we have a couple of questions around different types of regulations and confirming if this applies or does not apply. So one was about 822, which is OASIS license and programs. I assume this does not apply because OASIS has their own process, so I just wanted to confirm that.
Correct. This is just for Article 31 clinics.
Okay, and two other kind of similar questions. There's also a question about 598 regulations, which is the integrated care. Would this apply to that type of a license?
That one I will have to bring back to our subject matter expert in that area. Right now, the 598 regulations, I think, call out specifically what the requirements are, and so you would need to still follow those at this time. So I would, even if you potentially have a contact who you work with for your integrated services, maybe reaching out to them just to verify that information as well.
Okay, thank you. And one more in a similar vein, there was a comment and then a question. It states, this is for the children's side, so there was a Part 587 Children's Aid Treatment Regulations that ended, and those providers were asked or were advised to move to 599 regulations for guidance. And so the question is, would this apply to those regulations as well? So I don't know if Bonnie or others know this.
I will have to bring that back. I don't want to give the wrong information, just to confirm the answer.
Okay, thank you. So just moving along, there's also a question about if Medicaid, fee-for-service Medicaid, is a secondary payer. I assume this is probably in reference to dual eligible, meaning Medicare, Medicaid. Would this be applicable for those folks as well?
I am going to probably have to come back to that one. I believe my understanding would be that if somebody is Medicare, Medicaid, it would fall under the fee-for-service versus the other payer category. Mm-hmm. But assuming that Medicaid is secondary to like a commercial, yeah, we'd have to come back to that because I don't actually know how that would work in that situation.
Okay, all right. So the next one is a question, I guess, or a comment, but I'll read it. So it states, so right now, with this new regulation, the move is to 30 days. And the statement is that under the previous, I guess, at this point, I can use the word previous regulation, it was 30 days or the fourth visit, and whichever was sooner. So the comment was that the fourth visit sometimes came before the 30th day, which made it that you had to do the treatment plan before. So I guess that was eliminated for this, and the person is thanking OMH. That's the case.
Correct. Yep, correct.
Okay. Excellent. Let's move on. There's a question about if a provider does choose to use the progress notes to complete the treatment plan, How would MD sign off on this? I mean, I suspect, again, that one of the rules is one is under certain circumstances, you actually don't need MD signature, so that wouldn't be a problem. But I guess under some circumstances, the MD signature is still needed.
Yeah, so if a psychiatrist's signature is still needed, they would sign the progress note as well.
Okay, makes sense, definitely. And a couple of questions actually we got still. I think I know the answer about nurse practitioners being able to sign off when the signature by, an MD is needed. And I assume the answer is still not available, but just wanted to confirm.
Correct. It's still not available, but our hope is as we continue this work, because this was just phase one and just the beginning of the work that we're doing, is that we would be moving in the direction where we could allow others to also be signing off on it. But as of today, it still needs to be the physician.
Okay. And a clarifying question. So it was mentioned that if you're adding services or intensity of the service, you do need physician signature. And just to clarify, what if you're removing a service or reducing, the intensity? Do you also need a signature by a physician?
No, only if it's increasing or if you're adding a service.
Oh, very good. All right, thank you for clarifying that. Just going through some of the questions. And I also will invite Yvette, and I know some of our OMH partners might have seen some of the questions they want to, go through as well. So please feel free to jump in. Couple of questions about NICE-CRE in regards to this. So I don't know if there is anything to mention about that.
The question about utilizing NICE-CRE for assessment still?
Yeah. Correct.
At this point, agencies can continue to choose what assessments or what documentation you use for different areas, and some agencies choose to use the NICE-CRE forms. But as a reminder, the NICE-CRE forms can be altered, meaning you can take that assessment and remove items that you don't want to include in your assessment or don't feel are necessary, or you may ask them in other areas. So I think my understanding is that it doesn't have to be in the same form that it exists if you did want to streamline it some.
Yeah, makes sense. A couple of questions about just clarifying about the participant signature, and we got a couple of folks just want to confirm that it's no longer required, but of course, needs to be documented that there was participant and family involvement. Is that accurate?
Yeah, so the idea behind removing the recipient signature, and I say removing the recipient signature as a task in itself, not the actual whole intent of having the recipient sign or family signing it, was really to take away that administrative burden task of printing out, signing, scanning back in, and doing those pieces of it. But it doesn't take away the collaboration and work with the individual and family on a treatment plan, and that should be documented. And documentation of it could be, not necessarily just that they were in agreement, which in some cases may be the case, but it really should be clear that there was a discussion back and forth, and that the information was presented, and where there may have been agreement or disagreement or discussion about working on something at a later time or working on it now. So I think there's multiple different ways as part of that documenting that you can put that into the record to make sure that people are aware that there was involvement.
Great, thank you.
Stacy, I see a question here. This is Yvette, sorry, but I see a question here. There's a question in terms of the distinction as it relates to documentation between fee-for-service and managed care. And so I guess someone is looking for a little bit of clarity of why the distinction between that.
You mean for the signature requirements and the 30-day initial?
Yeah, yeah.
Okay. So when the regulations were updated back in 2012, it was really like a clinic redesign, and it was related to some of the rate changes, the CPT codes, and as part of that, managed care was coming in. And so because managed care was providing utilization management, there was some more flexibility with what could be done around medical necessity based on having managed care as the insurer, or commercial insurers for the same reason. And so there was a thought that allowing those flexibilities, even just for those getting managed care or commercial insurance, would be helpful to agencies. We know in some cases it is kind of hard to actually operationalize that. But regardless, it is something that's available, and it may be something that you would want to consider or look at in cases where you're in a tight spot and you need a signature. You can always, identify if somebody is managed care or not. For example, if a psychiatrist takes off for 3 weeks on a vacation, which we know does happen. So even if you're not able to do that, utilize that benefit all the time, because again, we understand that it's hard to operationalize, even if you can use it as something that occasionally might support the work that you're doing.
All right, that's great. Couple of requests actually, and I guess questions about, just to talk again a little bit about the rapid re-engagement and readmission, especially around best practices, maybe reopening the episode of care, a closed case. Again, there's actually, we have a couple of requests. If you can quickly go through that again, especially focusing on initial assessments and initial treatment plans when you re-engage or, readmit somebody.
So yes, absolutely, because and we will definitely be coming out with more around rapid engagement, understanding that this is the first time we're really introducing this, and part of that is because of the changes in the documentation requirements. I think will make some of those areas much easier to be able to bring somebody back into the clinic. But looking at it kind of like your primary care doctor, for example. If you go in, you see your primary care doctor, you may not go back to see them for 3 or 4 years. We're not saying that long for rapid re-engagement. But when you come back, you're just brought right back in. There's not like you're not starting over. It's not that you're a new patient. You're actually, their existing patient, and they will serve you as such. You'll be able to make an appointment. Although clinics certainly are a little different than that, it's still that same idea that understanding it is helpful for clinics to be able to have that timeline for having a discharge. But this would allow somebody to come back and really be where they left off. So there wouldn't be a new initial assessment that would need to be done. You would just build on the assessment that exists already. You wouldn't do a new initial treatment plan. You would work off of the one that exists already. So it really is like reopening the closed chart to be able to serve that person where they left off. Now, it certainly when that person returns will play a big part in what that's going to look like. If somebody's discharged and comes back a month later, there may not be many changes. If somebody's discharged and they come back 7 months later, a lot may have happened in those 7 months. So the work that you'll do to bring the person back in may look a little different from somebody who's been gone for a shorter period or a longer period. But our hope is to allow these documentation changes to make it so that you don't have to be afraid of taking somebody back in after discharge, because you have to start out with a whole new assessment. You have to start out with an initial treatment plan. And there was timelines for all of that, which certainly made some of that work a little bit harder to be able to bring somebody just back in, especially when you're dealing with things like wait lists and other things that you're are challenged with certainly every day.
That's great. Thank you for running through that again. There's a number of questions, again, just to maybe folks join late or miss this. Questions about when does this become in effect? When can we start using it? If I'm not mistaken, this went in effect yesterday, and folks can start using these regulations as of yesterday.
Absolutely.
Okay.
Yep.
That's
And
great.
just to follow up on that, there's a number of questions
Yep.
in terms of where folks might be able to find the regulations. I think there's several
It's
questions that came in
Great.
asking. Yep.
Good question, Yvette, because I think somebody also commented on here that it wasn't not in the Westlaw yet. It is in the state registrar, and I believe it is around page 59. I can look to see what page it is while we're talking. But unfortunately, you do have to know which page it is on because I think it's a very long document. So I will look that up.
Okay. Thank you. Couple of questions about. Yeah,
I found it already.
Good.
And it's called the DOS publication. So I imagine if you went in, if you Google DOS publication, you'd be able to find the document. And it's page 14 and 15 that you'll see the updated regs.
Excellent. Thank you. And we had a couple of questions about utilization review requirements and just confirming that there's no changes to that.
No changes to that.
Correct. And in a similar vein, there was questions about billing codes or billing. There's no changes to that as well.
Correct.
Correct. The only thing I would mention around billing in particular, if you are updating, and I believe Bonnie was going through that slide, if you are going to be updating your EHR and your billing system and moving towards this, please make sure that whatever you might have said before, that you also work closely with your EHR and billing system to make sure that it reflects the new regulations. Again, assuming you're implementing these right away or whenever you do, and just be mindful of your systems. But yeah, there's no change to the billing codes, but you might have your own internal processes that just make sure you check on those before you move forward. Couple of questions around managed care insurance companies, and folks just want to make sure that managed care is informed, will be following this, and will be supporting this. I guess especially those who might not have their own standards about 30 days or psychiatric signature and so forth. So I guess the question is around managed care companies themselves.
Yes, that is a great comment. Thank you. And we'll make sure we're working with our managed care division on that to make sure that they're aware that the changes have gone through and that the updates exist. And we'll talk to them if there's a need for a presentation on this as well for them.
Got it. Thank you. We do have another comment I just want to read that just came in the middle. This changes health clinician focus on clients, not paper. This is wonderful. So just so far, it seems like you guys are on the right track here. So this is great. So just because we have quite a few questions, just looking through other ones.
Oh, perfect. I just also saw, I don't think you just noted and mentioned this, but you guys posted the site on the chat box, so anybody who needed to go in, and I think it was verified that the pages were 15 and 16.
Excellent. So there's a couple of just, again, clarifying about when things, being very specific kind of start. And, admission date versus completion of the initial treatment plan. And so when Omid says it's, no less than annually, is this from the date of admission or the date of the initial treatment plan completed? So one of them, we had a number of questions like this. So there was an example. So for example, if somebody was admitted on January 2nd of 2020, and the initial treatment plan was completed on January 31st, 2020, is the treatment plan review due by December 31st or by January 31, 2021. Hopefully you were able to follow that.
Yes, I think I did. So it would be based on the admission date, so that would be December 31.
Okay.
But having said that, there is a strong possibility that because it's no less than annually, so you would update it if you needed to prior to then. If you ended up doing a full treatment plan review prior to that time frame, it would then be based off of that new date. So if you happen to do a treatment plan review, let's say July 1st, then it would be a year from that July 1st date that the next one would be due no less than. Did you follow that?
Yes. I did. I don't know about everybody else, but I did. Excellent. I do want to clarify, again, this is for the focus on the children's providers. There is a question about, does this apply to CFTSS? I believe the answer is no, as CFTSS are not part of 599 regulations in clinics, but I just want to double check that with Bonnie before we, in confirming that answer.
You are absolutely correct, Boris. This does not include to CFTSS.
Excellent. Thank you. All right. Let's continue with some of the questions here. All right. I'm just scrolling through because some of it is, repeating from what we already asked. A lot of when, which we again said it was effective yesterday. I don't know if Yvette or if others have seen any questions. I'm trying to find something different. There is actually from, I guess it's state-operated facilities about Mars, because every time I see Mars, I automatically go to state-operated facility. And a number of questions, will Mars be updated, with signatures and a lot of different things. I suspect that would be discussed internally with OMH state-operated facilities as their own process.
Yes, correct.
Excellent. Okay. There is questions about pre-admission, and again, kind of talking a little bit about, how many assessments you can do and the whole piece about, quickly in admitting the individual, and in particular how, if you maybe again can talk, quickly about pre-admission and how this does not eliminate the pre-admission status, because we did have a question about that. But I think you did talk, Stacy, about how to approach the pre-admission, and especially with rapid engagement and so forth. So you want to spend a couple of minutes again kind of reviewing that?
Yes, I think I understand the question. So pre-admission has been just a status. So whether somebody's in pre-admission or admission, billing and rates don't change based on that. So if you bill, for example, initial assessment in pre-admission, or you bill initial assessment in admission, it's still the same rate. And I know there had been at one time some question to that. Not everybody was aware of that. The idea of pre-admission was really to be able to allow clinics, if they weren't able to during one visit, be able to identify if somebody met criteria and was appropriate for admission, or whether the individual was interested in treatment through the clinic, that they could still bill even if the person wasn't admitted, and then the individual could have another second or a third appointment prior to being admitted to continue that process. So the idea would be that if at that first visit, if you're able to identify that they are appropriate for admission, there really isn't that need to delay. It was really meant to be more of a flexibility for clinics in cases where they needed more documentation or more time with the individual to make those determinations.
Got it. So a little bit more on that. So there's a question here around pre-admission and admission criteria kind of combined. So I'll just read it. So our pre-admission screening and assessment is somewhat extensive, but it's driven predominantly and consistently by added items from OMH. What is the minimally needed for admission criteria? And when they talk about added items, there's examples like health screening, TOB screening, SUD screening, risk, suicidal, violence, etc. Are these assessments or pre-admissions requirements to kind of admit the individual? So I guess in a nutshell, like what do you really need to admit somebody? Like what's the minimum?
All of those screening and assessment tools aren't needed to be completed before admitting somebody. Simply put, admission criteria is based on mental health diagnosis. That is very simply put. And I would say that we will be having new guidance coming out and hopefully really addressing that more. And when I talked about earlier in the presentation, how OMH is really looking at the assessments and the processes for it and what is required, that is exactly what we are talking about. We understand there are quite a number of assessments. There's a lot of different initiatives and CQI projects and other areas that are very important, but how do we prioritize those and what should that look like for clinics to be able to help you guys not feel like you're needing to do these excessive amounts of assessment, and certainly not prior to admission, but be able to still, really serve the individual well. So great question, and we're definitely absolutely looking into that. So I hope that our guidance coming out will clear that up.
Excellent. Thank you. I think it might be worth also, I know you early on repeated about how, agencies might still continue with their current processes, and even though there's new regs and updated regs, that they will not be penalized, so it's not going to impact them from the licensing perspective, because there is still a couple of questions about, is there going to be a grace period since people need time to update their EMRs and EHRs and all those types of related items. So Stacey, do you mind repeating again, kind of, even though this went into effect yesterday, but again, this is not going to jeopardize anybody's license if they didn't switch today to this new process?
Absolutely. So the reg updates have allowed for more flexibility. So if today you kept doing things exactly like you were, they would actually be meeting a higher threshold. Even though there's not necessarily a grace period, because regs are basically live as soon as they hit that state registrar, because you're meeting a higher threshold, there will be flexibility with that. So we understand that agencies are going to need to operationalize this, develop policies and procedures. If there's going to be electronic health record updates, that will need to be done. So as we move forward through this, you'll probably, each agency will be able to adapt to it at different speeds. And we will work with you to be able to make sure that, if tomorrow you're able to make all this happen, that's okay. And if you need 3 months to get there, we'll work with you as well to make sure that, again, we are able to maximize the flexibility, but also realizing that, agencies may take a little bit of time to need to get there, of course.
Excellent. Thank you. All right. Let's see what else we have here.
Yep. There
Go ahead.
are some
Yep.
questions. Yep, there's some questions that are related to whether the signature of the recipient is needed on treatment plans. It seems like there's a lot of questions that have come in around that. So I don't know if you want to just take a few minutes to clarify the reg change again.
For the recipient signature?
Yes, for the recipient signature. Thank you.
Okay, great. So the recipient signature is no longer required on the treatment plan. However, the recipient and family involvement in the treatment planning process has not changed. So if there is not a recipient signature, it needs to be clearly documented that involvement of the individual, the youth, the family, of their involvement in that treatment planning process, the development of the goal and objective. And so that information should be easily visualized when reading the chart for the involvement of the individual. And Bonnie, I don't know if you want to add to that piece too from the children's perspective.
No, I think you covered it, Stacy. We would, historically though, I would add that some clinics did view the signature as consent for treatment as well. So you may want to take a look at your individual policies for how you allot for consent.
Okay. Excellent, thank you. We do have a number of questions about telepsychiatry, telemental health, and again, just like with billing and utilization review, this does not impact any guidance or rules around telepsychiatry, telemental health, correct?
Correct.
All right, just wanted to just say that out loud. We did get a number of questions on that. See what else we have here.
There's also some questions, I'm just going to jump in here, as I see some questions coming in around whether or not this guidance supersedes the emergency regulations for COVID that are existing. So I don't know if you want to just speak to that quickly. I imagine it does not, but I think folks just want to be clear about that, yeah.
Yeah, so right now, for as long as the emergency disaster is in effect, and I think the date is as of today until 9/4, unless otherwise determined to be extended. And in that case, the current guidance on our OMH webpage for any COVID-related emergency information is what it should be followed still. Or what can be followed still, I should say.
Okay, thank you. I do have a question about progress notes again, and if you do choose to go the progress note route and providing a copy to the family or the individual of the treatment plan, do you also then, I guess, will be providing the copy of the progress note at the same time, or do you need to copy or somehow separate the two?
I was gonna answer that, but I think, that's part of the agency really looking at how to operationalize it. And so I don't want to necessarily say what would need to be done for that. I think it will be good to talk through how you see that playing out and what would be best for your agency. And Bonnie, I don't know if you want to add in, because I know there was some family language in there.
No, I agree. I think each individual clinic will have to operationalize their policies.
Okay, excellent. I don't think this is necessarily a change, but I will throw this question out because I know it comes up often around clinics. And the question is there any requirements that a client receive an evaluation by a psychiatrist during the course of treatment if medication is not being prescribed?
If medication is not being prescribed?
Correct.
The
psychiatrist needs to evaluate the individual.
Yeah, I'd have to look at that to be sure, so I apologize. I don't want to answer it wrong.
No, that's totally fine. All right. I mean, a lot of, I think we touched upon most of these, if not all. We also, I just wanted to mention, there might be in the future additional information, right? Just again, repeating that, Stacy, what you talked about early on during the presentation about standards of care being updated, including information that's going to come out around that, and potentially even more around these regulations. So just wanted to say that out loud too. I don't know if you or Bonnie wanted to add anything. So just let folks know around that.
Thank you, and I'll add while you're looking at questions. I just want to again thank you everyone, because I know that we have definitely reached out to stakeholders and really gotten to speak to a large number of clinics, and it has been extremely helpful initially for these beginning changes, and certainly for the changes that we're even going to move forward with as we move forward. So we have a lot of work ahead of us, but we appreciate you guys putting time and working with us so that we're making sure that we're doing the things that will be helpful for you. As you know, we do have federal and Medicaid and CMS, and I know those are all federal, but a lot of requirements that we look at, but knowing from you what could be helpful or what isn't working great helps us to know what to look at and focus on, and be able to hopefully address where we can make some changes.
That's great. Yeah. I appreciate it. We do have a couple of questions around, will Medicaid regulations follow this? And will Medicaid accept this? I'm not sure if that also implies, other things, but I just wanted to throw that out there because we did get like 3 or 4 questions around Medicaid following this.
I might be missing what the question is. So you mean like OMIG?
Probably. That's probably
okay.
Maybe where it's heading. Yeah.
So that is some work that we will do as well in working with OMIG so that they're aware of these changes and are building that into their process.
Okay. Thank you. All right. Anything else? I think, Yvette, I don't know if you see any questions that we haven't really touched on, or if Nicole, Stacy, or Bonnie, if there's anything else you wanted to add before we maybe close off this presentation.
No, Boris, it looks like we've attended to most of the questions here.
Nicole,
thank you.
Stacy, Bonnie, any last words?
Thanks, Boris. I guess I just wanted to, again, reiterate Stacy's appreciation for your collaboration, both prior to these changes, but then moving forward as we really try to look at additional regulatory or documentation and or policy changes that would truly get to a place of better treatment, better service provision for the folks that we're trying to serve. And we know this is an incredibly challenging time. So I think more than ever, trying to evaluate what we can do better is important, and we look forward to doing that with our providers. So thank you.
And thank you. Thank you to all of you guys at OMH for this presentation and making all these changes, and looking forward to additional parts to be working on together. All right, and thanks for everybody again for joining today's presentation. As Yvette mentioned, we did record this, and this will be available and posted on our website in the near future. So please look out for that. We will send out an announcement when this is available. Again, thank you, and have a great rest of the day. Take care, everybody.